say front row.
First row kind of guy. Good afternoon, everyone. I just wanted to let you know we're going to get started in about 4 minutes, so it's a good time to replenish your glass of wine, make a new friend, and have a seat when you're ready.
Do you care who sits where?
No, I don't. I just want to make sure I'm in your byline.
I'm going to be right here.
I'm happy to hold it too.
No, don't let me lose my scarf. Here, I better not. I don't want it in your video. Do you mind? It's my daughter's actually.
Yeah,
it says Emerson.
Purple, so it's from Emerson.
Yeah, well, it's from Emerson College, and her name is Emerson. So every time I go to Boston, I'm like, I'll get their name on it. She has a scarf.
What? Oh, thank you.
Those shoes are awesome. Super cool. Notice I didn't even pretend to put mine on.
Yeah, I gave it to Marty so I could be engaged.
I'm engaged. What are you talking about? I'm looking to see if anyone tweets any.
Oh, nice.
I'm just kidding. Let's just be honest.
Good afternoon. Hi, everybody. We're going to go ahead and get started on time because you guys are busy people, and you may have lots of good questions, and we want to make sure we leave time for that. But there may be a few more people that drift in. Hopefully there are. Otherwise, you have a lot of pressure to eat a lot of cheese. My name is Leah Namias. I'm the Director of Programs and Community Engagement at Indiana Humanities, and it's my pleasure to welcome you here today for today's InConversation with Dr. Jennifer Walthall and Chad Priest. And Jen, every time I introduce you that way, you say, call me Jen, so we'll do that. I'd like to also send a special welcome to everyone who's viewing online for the live stream. We have a class at Marion College that's viewing, and probably some other folks around the state. If this is your first Indiana Humanities event, welcome. I have the best job in the world because at Indiana Humanities, we connect people, open minds, and enrich lives by creating and facilitating programs that encourage Hoosiers to think, read, and talk. This afternoon's conversation is our first Quantum Leap program of 2018. Last year, we launched our Quantum Leap initiative, which is a 2-year initiative that will explore and is exploring the spirit of possibility and problem solving that occurs when we bridge the humanities with science, technology, engineering, math, and medicine. Through our programs, grants, and partnerships, we're discovering how Hoosiers, people like Jen and Chad, have, do, and could innovate to create a better world. And of course, since we're the humanities people, we're always asking what exactly we mean by better. You may have picked up a Quantum Leap card deck on your way in. Does anyone have one that they want to demonstrate for the class here? It is like a little card on a ring. Yes, okay. If you didn't, you should before you leave. And that's full of factoids and discussion prompts to get Hoosiers thinking about STEM and innovation in our state. And you also will have a card at your seats that shows some of the other upcoming Quantum Leap programs this first quarter. There is no doubt that one of the most pressing issues facing Hoosiers today is the opioid crisis. According to the Alliance for a Healthier Indiana, more than 1,200 Hoosiers died of drug overdoses in 2015. This is the part with statistics where you really want to make sure your notes are in front of you. Hoosiers are more likely to die of a drug overdose than a car accident. We all know about the cascading effects of the opioid crisis in places like Scott County. I have a good friend who's a social worker who also sees in her work with kids and teens the number of teens who are struggling with addiction and the rising number of kids who are entering the foster system because one or both parents is either in jail or has died for opioid-related causes. The epidemic touches all of our lives, sometimes in obvious ways when we see our friends, family, and neighbors struggling with addiction, with overdoses, with health crises, with displacement, crime, or a raft of other issues. But there are myriad less visible ways that opioids are affecting our families and communities. When it comes to the question of how best to direct public resources, both time and treasure, we all have a role to play as citizens and taxpayers, for instance. The opioid scourge can feel overwhelming and intractable, which is why I was so intrigued to come across an article in the IBJ last summer that discussed how Indiana's Family and Social Services Administration, under the leadership of Dr. Walthall, has been using data to address the crisis. It's just the sort of problem-solving attitude that we're interested in exploring through Quantum Leap. Dr. Walthall, who holds an MD and an MPH degree, both from Indiana University, is one of the people you're really grateful to have working in state government. In addition to being a professor of emergency medicine and pediatrics at the IU School of Medicine, she has a strong record of public service. Before being appointed Secretary of FSSA by Governor Holcomb last January, she served as Deputy State Health Commissioner and Director of Health Outcomes at the Indiana State Department of Health. She takes a public health and wellness approach to policy decisions and is committed to strategic alignment across government and the private sector to improve Hoosiers' health outcomes. Today's conversation about big data and opioids touches on a few of Quantum Leap's themes. There's obviously the problem-solving opportunities afforded by technology and big data to collect and synthesize data. There's the question of the practice of medicine and public health itself, hitting on what I would call the extra silent M in STEM, which is medicine. And of course, there are the humanistic questions that frame all these practical considerations. What kinds of data should we collect? What ethical considerations should guide the collection and usage of such data? Is there anything we should be cautious about? How do people in the midst of a crisis think about these issues? What guides their choices? What problems can data solve? And are there ones that can't be solved with data alone? And how do we build or rebuild resilient communities in the wake of the opioid crisis? I can't think of a better person to guide today's conversation than Chad Priest, who's the Chief Executive Officer of the American Red Cross Indiana. Chad, who holds multiple nursing degrees, a law degree, and also served in the U.S. Air Force, has long worked at the intersection of healthcare emergency management, crisis leadership, and community resilience, with an enduring focus on how law and ethics fit into public health and medicine. He has very strong humanities bona fides. He started book clubs for nurses at the IU School of Nurses in a previous life. He also serves on the Quantum Leap Steering Committee at Indiana Humanities. He's super smart, charming, and funny, but he's also willing to push people to think more deeply, more critically, and more systematically. In other words, he's the perfect moderator for today's conversation. I'm almost done here, I promise.
Keep going.
Okay. So here's how today's conversation is going to work. Shortly, I'm going to turn things over to Chad, who will talk with his friend and colleague Jen, raising questions and considering together the role of big data in responding to the opioid crisis. They're going to talk back and forth for a while, and then Chad's going to turn it all over to you to ask smart, insightful, thought-provoking questions and comments. Our goal, despite the large group and room, is really for an intimate and candid conversation. We're unscripted, so we don't know where the discussion's going to end up. We want to balance the opportunity to learn for people who are kind of new to this conversation, but we also know that there are people here who have a lot of experience, and this is part of your daily life, and you have expertise to share and build the conversation with us too. So we'll take questions from you guys, and then we're also able to field questions from the live stream, so we may pop up with one or two of those as they come up. So if you're watching at home, type in your questions, we'll find them. And you can tweet throughout. There's the hashtag up there on the board. You can use the hashtag InConversation or tag us at Indiana Humanities, and we will retweet your thoughts and ideas. At the conclusion of today's conversation, we're going to welcome Claire Fidian-Green from the Richard M. Fairbanks Foundation to share a few words about the Foundation's work to research and respond to the opioid crisis. And I really, really want to take a moment to thank the Richard M. Fairbanks Foundation for supporting today's InConversation, and their support specifically enabled us to do the live stream and recording because there were people who wanted to be here who couldn't, so we're really grateful for that. I also want to send a heartfelt thanks to our friends at WFYI, including Gail Strong and Clayton Taylor. Earlier this month, we realized there was more demand for today's event than we could fit in our space at Indiana Humanities. So we panicked, and then we called the people who solve problems at WFYI, and they offered to host us here. We're really, really grateful. And I encourage you to learn more about their side effects reporting initiative, which is all focused on health in Indiana, and there's information at the back table about that. So that was a very long introduction, but without further ado, I'm going to turn it over to Chad and Jen. Thank you guys so much.
Thank you. Thank you.
Are we on? We're on.
Well, hi, Jen.
Hey.
I say that this is, I think if we didn't do the work we did, I think we could totally have a TV show. You'd be the judge by the time we're done. You might be like, no, no, you couldn't. First, let me just say what an honor it is to get to publicly do what we do all the time, which is not only is Jen a revered public official and super smart doctor, she's also my colleague at the School of Medicine, and so we usually, when we're talking, no one wants to listen. And now
they don't.
We get to have this conversation with you, so thank you all. I'm going to start by, so what I'm going to do, if it's okay with you, is I'm going to ask questions of Jen, and then I'm going to sort of say things every now and then I'm going to let her be much more intelligent than me. But I think the real threshold question here, because big data has become pablum, like it's just a thing we say. So, Jen, Madam Secretary, 2 questions in one. What is big data, and why am I talking to you about this? Like, what's your deal? Like, why are you here?
Well, not to go back all the way to the beginning, but I'm just going to walk you through this little entertaining path. So I'm a daughter of farmers. And, back on the farm in Kansas, we did some really fun stuff like ride in the back of trucks at 85 miles an hour down country roads. And that was just kind of the norm of what we did back then. And we jumped creeks on 3-wheelers and did really dumb stuff. And the fact that all 12 of my cousins and I have all 4 of our limbs is really a modern miracle. So that was just kind of the landscape in which I grew up. And when I went to medical school and residency, there was a really pivotal moment, my second year of residency, when I was in the emergency department at Methodist, and I saw a little 4-year-old kiddo who had been unbelted in the back of a convertible and hit by a semi, and thrown from the car and then hit by another car. And it was a very visceral moment. Like, this is what we are trained to do in emergency medicine, as you know. We take care of really yucky stuff. But it was, I don't know what it was about that particular moment. You never know what's going to get through your, thick armor that you build up in medical training, but that one really did. And so I was asked the very next year, as a third-year resident, to testify for some really important legislation that was called All Passengers, All Vehicles. And it was the idea that everybody in every car, in every spot, should be as safe as they possibly can. And I thought, I am the worst person in the world. I grew up on a farm and I rode in the back of trucks at 85 miles an hour and all the rest. But there was this vivid picture of this of this 4-year-old who I had tried desperately to save and couldn't. And I thought, maybe I have a story to tell. So I did. I went and I told the story, and I didn't know anything other than that one story. And the legislation passed, and I realized, maybe I need to know more than one story, because that story, though riveting and powerful and really tangible to me, shouldn't be the thing that's guiding legislation. So when I finished residency and became a faculty and became a research academic scientist, I did the analysis later on of what the all passengers, all vehicles, and then subsequently the booster seat law did for traffic safety. And I used our very first on-scene EMS data to answer the question of, did this make a difference? So when you look at 4 to 8-year-olds in booster seats, pre and post legislation, did we help make them safer? And it was really interesting because it was a brand new data set, and I needed to figure out how to make it work, and then I also needed to figure out how to make it talk to our electronic medical record, and it turned out it didn't. And so then we had a whole new thing, and so that process took forever. But when it was done, it was really beautiful, and it answered the question. And so, fast forward a few years later, I'm getting my MPH, and I'm thinking about how we can intersect GIS, so geospatial analysis, looking at questions, and do maps help us answer it a little bit better than just regular data, and how can we look at it a little bit differently? And so I looked at youth violence in central Indiana, and I tried to look at it with that same data set that I'd used before, EMS registry data, that we could geotag to the point of a violent event, but then make it communicate with the American Community Survey data, so we could look at mobility and housing and other violent crime and education and built environment, and look at, okay, we know that, yes, youth violence is occurring, but can we look at it and flip it on its side and maybe look at it in 4 dimensions? And it turns out that if with a little work, you can. Now you have to redefine some stuff and look at age groups and make sure that they match, and really be careful about how that works. But it's possible to take a question and answer it better with 10 data sets talking to each other than just one. Yeah. And so that's really the way that I sort of got from in the back of a truck, hurtling down a farm road, to thinking about how do we answer questions correctly and precisely, and then look at solutions differently than we have before. So is the answer to youth violence just putting up a light on this corner? Or is it predictive policing to make sure that everybody feels safe where they are? Or is it that we need to really look at housing blight in this particular place, so that we're redeveloping areas that can keep people safe better than we do right now? Yeah.
Wait. Yes.
Some people have said on the live stream they're having trouble hearing Chad, so just.
Well, luckily I haven't said anything, so you're not missing anything. So I can repeat what I said. That's not that interesting. I think you raised a really good point, which I think most, maybe for those watching or here, you'll say, well, of course, but I think we tend, for those of us, and I'm not a data scientist, right? I mean, I think I have a scientist title at the university, which is sort of funny, but I sort of barely pass statistics, in full disclosure, which is, we'll talk about this later, which is why big data is so awesome. Right, because you actually don't need statistics if the data set's large enough, which is one of the reasons I like it. But this idea that big data isn't a thing, and you mentioned this idea of multiple data sets, right? It's this triangulation, multiple things that begin to paint a very different picture, right? And in some ways, the creators of these data sets had no intention of these ever being used together. And I think that that's remarkably interesting. I think that's just fascinating, and I think it raises, and we'll talk about this later, some of the ethical issues, right? But what's really cool about it is you were able to take 2 separate things and sort of make them work. And I think for those who are just getting into thinking about big data, is that there isn't like a big data catalog, right? You don't go to like Amazon and order up a huge data set. Although Amazon is itself a very interesting and huge data set, right? So anyway, I just want to highlight that because I think that's a key piece for a lot of folks who may not be used to talking about big data?
So when I think about what big data is, it really is just making sure that you're able to find a common language between multiple things that haven't been able to speak to each other before. And so there's this really interesting team. It's called the Management Performance Hub, and I've been really privileged to work with MPH, or Management Performance Hub, since the day that I set foot at the Indiana State Department of Health. Their first kind of trial project was to see if they could make a bunch of different things talk to each other and then spit out something that made sense. It wasn't meant to change the world. It was just to see if it was possible in the first place. And just the idea of that one data set may have age groups categorized this way and another one may have them categorized this way, and that none of these collection modalities were ever meant to communicate. So we started with the idea that we could take vital records, so birth certificates and death certificates, women, infant, and children, so WIC data, which is early nutrition, Medicaid data, which is claims and did you go to the doctor and how much did we pay and where did it happen, and put those all together and make some predictions about infant mortality. Like, are there some conclusions that we can make about why so many babies die in Indiana and where and for what reason? And so we went through this process and we spit out a couple of really important things. One, we can relate these data to each other. Even though they, on the outside, don't look like they would ever communicate, you can. It may not be causative, and that's really important, right? So
sure.
We can't say, this caused this, but we can say these things are related, and it's where we should look.
Yeah, I'm glad you said that, because I think those of us who play around in big data space can get a little loose with this, and our statistical colleagues will often remind us it's not just job protection. They'll indeed remind us that some of our conclusions may not be actual. So I'm glad you mentioned that. I hadn't planned on asking you this, but I'm sort of curious. Do you have like a favorite data set?
Absolutely.
And if so, would you share?
So am I allowed to have two?
Yeah, it's yeah.
So the Medicaid data warehouse is my favorite data set.
Okay.
And it's so much my favorite data set that I decided that it shouldn't just be mine. And in November, we made it open source.
Oh, cool.
So we are the first state in the country to have de-identified Medicaid data out there for all of you to play with. And we wanted to kind of showcase this to the world, so we had a 24-hour hackathon where we brought individuals who know how to work in these data areas, and we let them play around with solutions that they might be able to find. And if you did this for 6 weeks, I think we might save the world.
Yeah, for sure.
And just to have a bunch of kids, and I can say that now that I'm officially old, but a bunch of kids in a room looking at this open source data. We had 27 sets that we released, and they're on our MPH hub. And they made some incredible programming conclusions out of looking at this. And the winner was pretty easy. So our chief information officer, Jared Linder, who was just the way to make this dream that I had in the back of my head become a reality. He asked one of the teams, so if you could go to one place in the opiate epidemic and do something, where would that place be based on what you've looked at in our Medicaid data? And the kid, pushed his glasses up and said, no problem. Like, does a little clicky clicky and then goes, there. He said, you win, right? Because that's the kind of things that you can do when you play around with the way that our most vulnerable populations engage with their safety net. It lets us know where, what, when, and who we need to be helping more, and we need to be helping differently. So that's my favorite, number one. Number two is I still have a really soft spot in my heart for our Indianapolis EMS data registry.
Me too, by the way.
And the reason for that is, one, it was what I used for my first two big data studies, and number two is it captures the humanity around people at their worst moment. It's not just where you called when you had your first episode of chest pain, but it captures the narrative of what the circumstances were that surrounded that. Who were the people that were there? What was the house like? What were your circumstances? And there's so much that we can draw from not only the point in time, but the place, and again, the humanity that happens when our EMS providers go and take care of people in their homes, in the real world. And if we capture that, I think it really informs what we can do better.
Yeah, and I think that and I love this data set, which for another reason, which is that I think really good big data sets are often the result of people who work really well together. So I'm often amazed when I go other places and I say, a great example, today, I was in a research meeting with my colleagues and someone said, I have this idea, I want to go look at this thing. And someone said, okay, we did that in 2002. It took a 2-year prospective study. And someone looked and said, I think we can do that in 10 to 15 minutes. And the beauty of that was to make that happen, it was not just EMS, it was the Indiana Health Information Exchange platform, it was all of these people. And that is a kind of, in many ways, like we're really lucky in Indiana, right? To be able to have a level of connectivity, I don't want to say it's abnormal, but we certainly take it for granted here. And I will tell you, it fuels knowledge generation in this mega way. You talk about force multiplier for knowing, right? What it is to know. It turns out that like Hoosier cooperation is a huge catalyst for knowing things. And you know, I think that's exciting and interesting as well. Okay, so it turns out though, Jen, that we're like talking about big data like it's new, and our colleagues in the commercial sector, right, would say, yeah, well, you know, we were doing this in like 2005 and 2006, and when you go and you search something on Google, and the next time you go to Amazon and it appears, right, there's a whole industry that have figured this out, right, in a major way, and we're sort of coming at this a little, I don't know if I'd say late, maybe more deliberately. So tell me what's changed in health and medical research, and what's been the sort of arc of that change from your vantage point around big data before we get into sort of opioids and specifically. So talk to me about the sort of arc of change, you know, for healthcare. Like, why are we just now getting to this? What were the barriers in your estimation, or the things that fueled it?
Well, one, I don't think in healthcare in particular that we really knew what we had for a long time, and there's this. Well, we do what we do, and I liken it to the disconnect between emergency medicine and public health. And in the emergency department, I can be a really good ER doc and take care of one person at a time. And that is fulfilling, and it's what I trained to do. Or I can do a really good job taking care of one person at a time, and then I can step back and think about what they taught me about the millions of other people that they represent. And so the combination of both of those things, I think, has a parallel with big data. You can think about your EMR as, how do I take care of this one person?
Electronic medical record.
Electronic medical record, sorry. How can I take care of this one person because I have a good comprehensive view of how many times they've come to see me in the emergency department, have they been to their primary care doctor, what medicines have they filled or not filled, and I get a view of them. Or I can think about that person and then all of the other people that might have the same or a similar experience, and I can look at them from, you know, the buzzword from a population health level of how can I make sure that not only this guy gets the right stuff, but all the other people that need the right stuff get that stuff too. So I don't really think that we knew what the gold mine that we were sitting on, and then for a while when we realized our gold mine, we thought, oh, I can't tell anybody that I have this gold mine. I'm going to get in really big trouble. And so, and that's actually legit. Our stuff about us is our stuff, and has to be protected vigilantly because we've seen what happens in history, and we have to learn from it when we don't protect it. So, but there is an incredible way to win-win, that we can protect our own personal health information incredibly well, but we can also use our personal health experience to help others' health experiences get better. And then it doesn't have to be just the electronic medical record information. That, when you link it with where people need other things, then we really can get down to business. So when we talk about the electronic health record and population health and managing things, one of the biggest pieces of feedback that I get back from hospital systems is, why don't we have all the stuff that you know in our electronic health record? Why don't I know just by pulling up a chart that this gentleman is homeless or illiterate or needing nutritional assistance? And why am I not able to factor that into my decision making, not only as a healthcare entity, but as an individual provider? And the answer is, I don't know. We can do better. And one of the great examples for the opiate epidemic in particular that I think is a great shining example of how we can do better is our commitment at the state level to integrate InSpect data into all electronic health records across the state.
Do you want to explain
I'm going to explain
InSpect?
that.
Okay,
Yeah,
good.
that's my next.
What's
Yeah, you bet.
InSpect?
So InSpect is Indiana's version of what's called a PDMP, or a prescription drug monitoring program, which means that anybody who gets a prescription on both ends, so the person receiving it and the person writing it, that's a controlled substance, so narcotics are one of those, gets integrated into this statewide system. And from wherever you are, if you are a provider, so a doctor or an advanced practitioner or a dentist, you can see this information, and it can help you make decisions about what's the right thing for that patient in that moment. Is this somebody that might be at risk for an overdose because they've gotten a bunch of narcotics from a bunch of different places, and we need to have a real conversation at the bedside to make sure that we're doing the right thing for you? So in the past, we've made that hurdle pretty tough, because if you're seeing 30, 40 patients in a shift in the emergency department, you don't have time to go to a separate website, look everybody up, and then kind of type in all this stuff. So this integration where you pull up a chart and this patient's InSpect information comes up with it to help inform your decision making, to have compassionate, real conversations about referrals to treatment, assessment of risk. Those sorts of things are really, really important. And they change the way that we do day-to-day business, but they also change the way that we think about how important it is that we know more than just your blood pressure.
Mm-hmm. Yeah. I think, one of the, I was going to wait and do this, but I think it just naturally talk about it now, sort of this idea of keeping data, protected and what is public. And I think it's really interesting because how many of you here, or you can raise your hands if you're on the live stream, I just won't see you. How many of you have Facebook pages or Twitter accounts where you transmit something into the universe? Well, I do. And we consider that public data. And I think for many, IRBs, everyone right now says, well, public data is public. And if it's public, then we can do whatever we want with it. And generally that is true, right? So from a strict research ethics standpoint, I think that's true. It gets tricky though when we start taking several public streams and merging them. So for example, I said one thing on Twitter, I said one thing on Facebook, I said something else out loud in the middle of the street. I never in my mind imagined that you would triangulate those three things to create this new thing. And I'll tell you that I'm giving you sort of the dystopian sort of way of putting that, but the fun part of this is at IU, I was giving a talk, and a person who's now a good friend of mine came up afterwards and said, I have this great data set, I think I can get it to you. And it turned out to be the entire Cha-Cha database. So every question, every answer ever issued by Cha-Cha, and Scott Jones made a huge donation to the school of this data, which we played with, the first people to play with it. And it turned out that we were peeking, right, anonymous, totally anonymous, we have no idea who it is, into these sort of intimate questions that people were asking. And some were sort of silly, like, what day is it? What's the movie that's playing? And then some were really, really, really fascinating. And then as you started looking at it by age and by gender, you started seeing the angst of adolescent women asking about, the first time they have, they're menstruating, and is this normal? Or you saw sort of the underdevelopment of teenage boys, right? So as we looked at the same age group and the questions they were asking, and the boys are asking about, where do I get marijuana and how do I play Call of Duty? And the girls are asking, how do I know if this person loves me? And what does it mean to love, right? And it's fascinating, right? And you're sitting looking at this data and you're thinking, oh my gosh, this is so voyeuristic, right? And I don't know who it is, right? One of the questions though is, and I've struggled with this, and I'd love to hear your response, because you're seeing this in a different way, in different venues, right? Appropriately protected. What is our obligation when we see things to do something? And I suspect you and I have different views on that. So I would love to hear your view.
So I, in this role as directing sort of the social service world of Indiana, so if you need something I most likely have it. Is that's exactly the whole point, is that if you see something, you have to do something. And I take that responsibility extraordinarily seriously. And I as you know, I still work a shift in the ER every Tuesday to keep that real. I worked last night 3 to midnight, and we got, oh my gosh, pummeled by the flu. Please get your flu shot if you haven't gotten your flu shot. And it's the idea that micro to macro is not either or, it's both. So I love my complaints department email inbox because it's solving real people's problems in a real-time basis. But then also, again, that lens toward what's the big picture that this person represents. And so I think what big data and the de-identified, you never know who this person is way, but it's I see a real problem evolving in front of me with this data set, is what do we do about it? And I'll give you a quick example of what that looks like in our programming now, specifically around opiates. There's a couple of big things. The first is that we have built, in that same management performance hub, a drug dashboard. And the drug dashboard gives me every Monday in my email inbox the who, what, when, and where of what we're seeing across the state. And so we have emergency department discharge data of non-fatal opiate overdoses. We have coroner's reports of, again, fatal overdoses. We have the Indiana State Police, which is probably our best treasure trove of information about where and what drugs are being seized. So if we can see that new stuff is popping up in a place we didn't expect it before, that gets overlaid. We're also seeing those precursors, right? So hepatitis C cases that are increasing. All kind of layered into one piece. We're seeing pharmacy robberies where those occur. And as we see places that pop up in these overlays, if they're new, it gives us an opportunity to go and say, what does this particular place have in the 3 buckets that we really care about? The first is the emergency, right? So people are dying right in front of us. We've got a Hep C outbreak or pharmacy robberies or things like that. Does this place need to think about their naloxone stores? Naloxone is the overdose antidote for narcotics. Do they have enough? Do their police officers have them? Does their EMS system have enough? Does their hospital system have a great group? Is this a place that needs to think about whether they should have a syringe exchange to prevent the harm, to do the harm reduction around injection drug use? So those are kind of those emergency buckets that we want to go and look at. And then, do they have enough treatment capacity? All the way from big time inpatient stuff, all the way through medication-assisted treatment that you can get from your primary care provider, all the way down to just having a peer recovery coach that's Velcroed to your arm, kind of helping you through the process. Do they have enough there? And then in the prevention arm, what are they doing in their communities, and what are they doing in their schools, and what are they doing in their faith-based organizations and not-for-profits, and kind of doing that assessment. And so as we built the drug dashboard, it's fine to know, but then what are you going to do about it? And so we had this incredible opportunity from the federal government last year to get $10.9 million to the state of Indiana to do innovative work around the opiate epidemic. And one of the things that we did was fund mobile addiction teams. And so those teams do just what I said. So they see a thing, and we say, go to here and look at this, and then help build in the emergency period the things that they need right now, and then build capacity within those communities for all of those pieces of the menu. Now, every community may not pick everything. They don't. Not every community in Indiana is the same, and that's the beauty of being a Hoosier, is that we have little pockets of awesomeness that happen. But pick one from each of those areas and figure out how you're going to own your own opiate response plan. And so again, it's let's find the thing, and then let's fill the need. But then I think the one thing that we forget to do, and that I'm hoping that we'll really do, is then let's see if the thing worked. Right, because one of my catchphrases, and I have many, as I've been made fun of many times, but is that let's not do things because they seem like a good idea. Let's do them because they are a good idea. And we'll never know if they're a good idea unless we actually, on the back end, look at whether our good idea did what it was supposed to do, and then have the courage, and I say this out loud because you'd think that this would be easy, but it's not, but have the courage to scrap the bad ideas and do something else. And the courage to scrap bad ideas means that you're not bought in to a presupposed solution, but you're actually wed to the idea that we're going to look at it. We're going to look at it objectively, and our outcome is to help people. And if you don't assign your name or your pride or your whatever to your idea, it makes it a whole lot easier to scrap it on the other end. But then let's put our energy toward the next thing that might modify that just a little bit better. And that's really where I think the big data part is important on the front end, but potentially even more important on the back end, which is to say, okay, we had this information, we did a thing, and did it work?
Yeah. So you also on the opioid side, so you've described sort of using geospatial information, data from police, law enforcement, healthcare to sort of figure out hotspots and then sort of respond. But then there's also big data you're using sort of in the moment, in real time, which is super cool, to sort of help decision making immediately through open beds. So can you talk to us about open beds, what it is, why it's so awesome?
Yeah, absolutely. So this is my example of the phrase working at the speed of government doesn't have to be something that you say under your breath. So I'm really excited about this. We realized, and this is preceding me, of course, but we have something called opiate treatment programs, or as we affectionately refer to them as OTPs. And when I started, we had 13 OTPs, and this was referred to in the Indianapolis Business Journal article that was talked about before. When we were starting to think about our ability to expand our treatment capacity, we realized that, and the General Assembly was really kind to allow us to think about having 5 new OTPs, but we got to decide where they were. And so we used our data system to change the way that we did the RFP process, which is our call for people, hey, do you want to be an OTP provider? And not just to take anybody, but to change the way that we graded our review of these applicants based on need. So we took a map and we overlaid where our opiate overdose deaths were occurring. And then we also mapped that with distance to the nearest opiate treatment provider. And we weighted the way that we graded our applicants to be an OTP based on where their geographic and population need was to fill the gap. Because I'll tell you what, there are some places that don't need another OTP. They just don't. They've got plenty, and we're doing great, and we're going to make progress, and it's wonderful. But there are some places that your people were driving 3 and 4 hours just to get a medicine, and they weren't able to go home to their jobs and take care of their kids, which is the whole point of an OTP, is that you just do what you're supposed to do. And so we got a little bit further in this project, and we were really excited about really thoughtfully placing OTPs. And then we got this feedback, well, okay, this is really good, but we keep getting this pushback that there's this big wait list. And people are coming in and asking for treatment, and they're being told, you know, we don't have anything for you, come back in 3 or 4 weeks. Now, I'm a behavioral scientist, and so I know that that actually doesn't work, that the teachable moment is right now. If I look at you and say, I'm ready to quit smoking, or quit heroin, or whatever, or stop eating chocolate cake for 3 meals a day. You know, whatever that might be, I need to respond to that with something tangible right in that moment, because that sort of stages of change process is very transient. And so asking it to come back in a week makes sure it guarantees the results that we've designed, which is I walk out, I go right back to the person who's been supplying my heroin for a long time, and I say, well, they didn't have anything for me, what's next? So we also realized very quickly that the wait list was this fleeting thing that didn't actually exist. There was really no wait list with a capital W that gave us a statewide view of what treatment capacity we had. What we had was the 2 o'clock in the morning on Saturday, somebody shows up and says, I'm ready for treatment, and you call around to the things that you know, and they say, we don't have anything right now. And so you say, come back next week and we'll try to find something for you. But it doesn't give us the worldview of everything that we have. We didn't even know everything that we had. And so through a little bit of persistence of my team, who I'm trying to solve this problem, and I'm a bit of a slow learner, and I got to figure out what's going on, there was this incredible marriage of an old friend and a new one. And the old friend was Open Beds. And Open Beds is a software system that was designed at Johns Hopkins to deal with disaster management. So if you have something horrible or cataclysmic like a tornado or a volcano or a hurricane, Open Beds is designed to always know what capacity is available in your area so that people can go where they need for the quickest, most responsible treatment for their issue. And so the question was, can this software actually be adapted for mental health? And the answer was, you bet it can. And so what this is it's a data platform to connect people at their point of need, whether that's in their doctor's office or hopefully eventually in their pastor's office or at their library or wherever they present to a trusted person and say, I'm ready for something different. That gets connected on the other end, almost like an eHarmony for mental health services. On the other end, with all of the open availabilities in our mental health system that connect in real time, 24/7, 365, to really capitalize on what we know about behavioral science. So OpenBeds is a great platform, but it took me a while to figure out where it needed to live, because FSSA is not a 24/7, 365 organization, and we don't take that kind of data, right? We don't take real people information and then connect it to other real people information right then and there. We do a bunch of thinking and processing and bureaucracy. So, but with our new friend, Indiana 211, and its rejuvenated life, is a 24/7, 365 operation. And so we at FSSA decided that this was the perfect marriage of true big data. So the platform is Indiana 211, and if you are a grumpy old ER doc in the middle of nowhere and you say, I'm not going to use OpenBeds, it requires me to type on the computer, you can actually call 211 and they will do it for you. And so what that does is it facilitates the connection between people in their moment of need and the providers who have really been growing weary of not knowing what to do next. And that's, I think, what we're seeing it manifested in some pretty crazy ways. Like, if you look at the physician suicide rate, I think it is a strong reflection of a lot of things, but one of them is a feeling of helplessness to do anything beyond what's sitting right in front of you. That when you let that person go, that there's no one else that's going to catch them. And in a small way, the OpenBeds 211 platform is meant to be the really, really imperative reassurance that we've got you. That you're going to send this person out into something that is, you can see, you can log back in and see how they did and make sure that they got there and what they needed to do. So we're starting in this spring. Again, speed of government, pretty exciting, with this going live. And we're piloting it within Medicaid. We have our arms around Medicaid providers, both from our hospital systems and physician systems, and then into our mental health community. And then the next step will be to take it out to all payers. And then the next step is to take it beyond inpatient treatment. Because the sort of the dirty little secret of substance use disorder is that although I wish it would be true that you could send somebody for a 5 to 7 day stay and then they come back fixed, that's not the truth of the disease process. And we have to be ready for everyone wherever they are. And so the next step is to take that into outpatient services as well. And so if if you really don't want to go into inpatient treatment because you've got a couple of kids at home and you've got a job that you need to go back to, is that immediate referral into medication-assisted treatment that's nearby, your OTP program or your primary care doc that is a registered Suboxone provider or naltrexone provider or all of those things, is to really make sure that we do have a wait list with a capital W that capitalizes on all this information that we have to say, hey, you know what, we may not have something within 5 miles of where we are right now based on my knowledge of what we have, but we have something about 20 miles away. You ready? And if the answer is yeah, okay, we've got it for you.
Yeah, that's awesome. And I think what this idea of sort of taking people with need, right, who self-identify and come into the system and say, I need this, and then figuring out how to optimize available resources for them. In your instance here, beds, or the original instance, hospital beds for a disaster or whatever. I think the next iteration of that, right, gets pretty crazy, right? Because the next iteration is, what if it's not a resource? What if it's another person, right? So to take your eHarmony example a step further, what if we started finding people in need, and then we started finding them in real time with people who could help them, which is interesting because we expect businesses, institutions, healthcare institutions, et cetera, right? They're used to receiving sensitive data about people and their needs, right? But it's a little different if I start saying, how do I connect, I'm in need right now of CPR, right? I just trained you to teach CPR. I know where you are because your phone's on and you have an app on that can geolocate it. This is real. This is not future. This is real state.
It's one of our residents out in Seattle.
Yeah, Stephanie's working on this. I mean, this is possible, and that has huge implications for caring for one another, right? Like this idea that we can use technology to sort of lean on each other in this way, but it also presents radical disruptive sort of problems for our sense of privacy, right? And what are we ready to share? And I don't know, I would, forgetting the official programs, like how do you balance, how do you think about this? Because this is the kind of thing I just freak out about, right? Like the nurse in me is like, we could go and fix all this stuff right now. And then I'm like, the lawyer's like, that is absolutely bonkers, right?
Well, we just had a recent example of this. We have a new cabinet member, Secretary Blair Milo. She is our secretary, and her title is super long, and I'm going to mess it up, but I'll just say she's Chief Awesome. So her job is for figuring out how to solve our workforce issue in a more complex way than just saying person without job. It's about the fulfillment that comes with skills training and education, and what do you want to be, and what do you want your life to look like, and do you want to land in this job and then be in this job forever, or do you want to find the job that takes you to the next thing that you might do, and how do you even know where to start answering that question? And so as we think about the opiate crisis, Blair and then Jim McClelland, who is our Indiana drug czar, have been thinking about where's the right place to go and start asking these questions. And it turns out in social services, we know a lot of things about folks. So we know all of our individuals who receive assistance from us for our Medicaid programs, or SNAP, which is our nutrition assistance, or TANF, which is SNAP assistance. We know those individuals, whether they have a high school diploma or not. And that's just something that we know. We don't really know why we know it. We just do. And Blair asked me, she said, well, wouldn't it be great if we could start just there and say, well, if you don't have a high school diploma, and we know that that's a great predictor for lots of really good things, ending the cycle of poverty, really, really cool stuff. If we could just start there and help those individuals get their high school diploma, would that be a good thing? I said, well, it seems like that would be a good thing. I said, but I can't give you any of that information. And she's like, what do you mean? We work for the same government. I said, oh, no. That information is mine. But it's how do we get to yes, right? It's yes, we have this information, you want to do this really good thing, I can't give it to you. But if you design a thing, a program, a communication, an outreach, and you give your thing to me, then I can give it to them, right? So it's that degree of responsibility that I have to making sure that people's their privacy, their ability to trust the people that take care of them, to really take care of them. We have to have those boundaries. They have to be there, because once we erode that trust, we've taken light years step back.
Yeah. I think it's important to point out it doesn't always work. And for those of you who know big data, you know that we've made, not Jen and I, we haven't made any big mistakes, I'm sure. But the people working in this space have made huge blunders, sort of by accident. And one that I wanted to mention, because we're in the peak of flu season, is Google Flu Trends. And for those of you who may remember, Google Flu Trends was really going to be the future of health data, right? Because a truism is what you type in the Google bar is always true, right?
Absolutely.
And it is true. If you think about it, what you say on Twitter and Facebook, there's a % chance that's a lie, but you're not lying to the Google bar, right? And so if you're a health person, knowing what you're asking Google, well, that's interesting, right? What does this mean, right? My body's doing this. What does this mean? Well, I'm interested in that. I'm interested in that question. And so Google started tracking flu. I have a cough. I have the flu. How do you treat the flu? What's the best thing for the flu? And they came up with predictive algorithms that said, look, there is going to be where the flu breaks. And they had a map, and they could point and say, there it is, right? And what was the big miss on Google Flu? Well, people would see on the news, flu is up. And they would say, oh, well, I wonder if flu is up, right? And so there was this limit in the data's ability to be sensitive, right? And so I point that story out because it sounds like a panacea, but I think it's worth pointing out that these are iterative steps, right? Where it's like one step forward, two steps back. As the data gets more sensitive, as we're able to parse it differently, we're going to get smarter. And so that leads me to my next question of you, which is, well, what's the next big thing? So like, forget maybe what's actually, well, I don't know, you can do whatever you want, but I mean, maybe you have something on tap to talk about. But more importantly, if you could wave a wand, right, in your desire to sort of use big data to sort of help people and move the needle on population health, what would be the next big thing? What would be the next cool big thing?
Well,
I know you have one, even if you don't know. Like, you'll have one before you finish the sentence, because I know you. So.
Well, I think if we're going to look at the opiate lens in particular, I think what our next step for big data is not just necessarily to build one program, right? It's not making sure that we have the OTPs in the right place, or enough naloxone for our first responders in the right place, or the open beds program. All of those things together make some incredible stuff. And it's not the mobile teams or our ECHO training programs that are going to help primary care docs learn how to do medication-assisted treatment. It's really taking us from individual solutions to individual problems into developing the system that works for things that are beyond just the opiate crisis in front of us. We've taken legitimate and well-founded pushback as to why are you just caring about drugs now, right? Why is the opiate crisis what opened our minds to the fact that there's something really bad fundamentally going on in society? Why didn't we care about it, with cocaine? Or why didn't we care about it with methamphetamines? Why now? And so my answer to that is, wow, I'm really sorry, right? And I can't go back in time, and not necessarily, I can't go back in time, right. But I can, but what we can do is say this is our starting point, that the systematic approach that we take for health, specific disease processes and public health in general is not really about opiates, nor should it be. It should be around fundamentally getting to what is the root cause of our inability to achieve the health outcomes that we're looking for in Indiana. And so I think what big data is meant to do next is to help us figure out what that is. So instead of saying population health and maybe not knowing what that is, it's saying what's the model that integrates on-the-fly healthcare, public health outcomes, healthcare delivery, private sector into one sphere that really, at the end of all of it, the outcome is something different than it used to be. And it's just that everybody has the chance to achieve the health outcome that they should, wherever they are, whoever they are, and whatever they do. And the data systems that we can tackle next and harness next to really answer that question better than just what we have at the state level is that really fun conversation, right? It's can we look at all of our electronic health information? I only have 25% of Hoosiers in Medicaid. The other 3/4 are invisible to me. And I want to make sure that we're making good decisions that aren't just based on the people that I can see, but the people that we can all see. And that we're engaging the business community and all in those kind of conversations around what that looks like. Now, I think, and I may be wrong, but I think what that looks like is that we don't recreate the wheel every single time. And that we regionalize the way that we think about health so that we've got some hub and spoke, and in the true Hoosier spirit, we actually help each other. And that we've got places where the data and the information that we need lives, and that it is shared widely in ways that make sense. And sort of the long-winded answer to your question is that I shouldn't be the only one getting that data dashboard in my email every Monday morning. And so the next step of that data dashboard is that every Monday morning, it's now public facing. So the mayor of Fishers gets it every Monday morning. And he can make decisions for his community based on information that he needs in real time. And our legislators can see that information. And our public can see that information to know, I need to start thinking about my neighbors. And I might need to replace the stuff that's in my dashboard in my car with a naloxone kit because I'm at a high risk for seeing or witnessing an overdose in my community.
And it's a great segue. We're going to go to questions, but I just got back I was overseas and working with the Magen David Adom, the Red Cross Society of Israel. And one of the things that they've done, which is a pretty phenomenal example of the trade-off between privacy and sort of helping your neighbor, is if you have a EpiPen, right? And you could just replace EpiPen with Narcan and nasal naloxone or whatever. And you can register, right, with the ambulance service, right? And say, I have an EpiPen. And just say, look, if there's an allergic reaction reported at 911 and I'm within 4 minutes walking distance of where that call comes from and my phone's on, a la Uber, I will take my EpiPen and use it on you. And when the ambulance comes, they will give me a new EpiPen to take back, right? And so you talked about it's not just my data, it's not just my information. Well, there is on the reciprocal side like this sort of really interesting moral question about whether we're ready to use this data in such a way to care for one another. And that technology exists. It exists in Indianapolis, or it will when the CAD comes in. I'm looking at the person who knows, Tom Arkins, who controls this data. That's another thing you should know, everyone who controls all the data. But will we use it? And are we comfortable with that? And what does that mean? And you know, I order food from Cluster Truck, right? This isn't an ad for Cluster Truck, but it is quite amazing. I order it, and then it tells me it's making it, and it's optimizing where the driver is with where I am, and it seems to know my hunger level at any given moment. And I get the email reminding me I haven't ordered in a while, just at the right time. And if we can bin that to public health, wow, that's pretty awesome. So if it's okay with you, what I'd like to do is open it up for questions. And if you don't have questions, I'll just keep asking them until we do. But we'd love to hear from you for Secretary Walthall. So questions.
Yeah. Chat, I'm just going to ask, since we are live streaming, if you have a question to go to a mic, there are two set up here. And I'm going to start you off while someone's getting to the mic. We had a couple people who are watching the live stream who tweeted at us.
Oh, we already know.
Okay.
We've already answered them.
Okay.
No,
Well, you
I'm
have
kidding.
answered many good questions.
Big data.
So one question from a student that's at Marian University asked, what's the data set you wish you had to combat the opioid epidemic specifically?
It's a great question. The one. Well, honestly, I guess my big answer to that is I wish that we had a nationally interoperable PDMP system, so that my Indiana Inspect information could connect with Illinois and Kentucky and Ohio and Michigan and Minnesota, so that I could really truly follow and help people despite the boundaries that we've sort of imposed upon them. I think it might give us a better picture of kind of the questions that we ask, which is, do we know the problem? Do we know where? Do we know who? Do we know what? And so I think that interoperability beyond just our current scope would be pretty extraordinary. Again, back to Chad's ethical questions of, we need to make sure that information is safe and used in the way that it was intended to. It's not meant to be policing. Right. It's meant to be helping.
Yeah, and on that note, I would just say that I think I want intention data, right? So I want to know, and this is, I guess, creepy sounding, but I want to know when you're about to make a risky behavior. And I think we're actually close to that. So for example, and I don't need to know it's you that's about to make the risky behavior, right? So this could be anonymous. But if, for example, you're doing things that give me the sense that you're about to take a risk, can I do something like push an ad in real time? Can I push a public health message to you in real time in a way that, just like the Gap does when you want a size medium and they're out? And that intention data, I don't think we're far off from that actually at all. It'll be a little different with opioids. But.
It's a really, it's an old concept, but there's a tool called SBIRT, which is a screening, brief intervention, and referral to treatment. And when we started thinking about using this process in adolescents in the emergency department, we thought, well, if you come into the ER with one risky, the outcome of one risky behavior, perhaps those things swim together. And so maybe we ought to ask about other risky behaviors. And so we did that, and we used a screening tool. So if you came in and you are 14 and you fell off your ATV and sprained your ankle, we asked about your alcohol use, your drug use, your sexual activity, et cetera, et cetera, et cetera. And it turns out that's true. So risky behaviors sort of flock together, and that opportunity for brief intervention and referral to treatment occurs before the really bad thing happens.
Absolutely.
And you're car surfing and you land on the highway. And so getting back to that, this is the thing that happened, but it tells more than just that one thing. And how then do we respond in the moment with that one right thing to change the course of your life? That can be one-on-one, but it can also be predictive in lots of other ways.
Yeah, excellent. Question over here?
Yes, hello, I'm Kelly Meyer with Health Visions Midwest. And one of the most difficult areas to account for data is in the social services arena. And when we're talking about, for example, I want to tie two little thoughts together and see how we might measure this and get a picture of what this data can be. The SAMHSA and the Surgeon General's office both tout that 80% of folks with chronic disease of any kind relapse without supports. Now, for example, we certify community health workers in the community. So we and other do-gooder organizations, we're faced with measuring also what some of those supports can look like, but stigma is such a huge barrier. That self-identification. And what we know in those social supports that we provide, when we're able to say, my client was just diagnosed with X, or I need to help my client navigate transportation or something, we're more apt to get the client to treatment and remove that barrier to that piece. So I know it's a hard question and it's a very tough one, but if we could somehow try to look at those data that can help us remove those barriers, especially with things so huge as stigma and what that extra social service can look like. And that's just a really hard one to hone in, but I just ask for it somewhat systemically so that we can kind of even promote the good work we're doing in a better way.
So do I understand, just so that you can address it, that what you're really asking is how do we take this data and use it to address sort of, are they barriers or conditions precedent to other things like stigma? Is that essentially what you're saying, or have I missed the mark?
Yes, but how can we measure that we're doing a good job when we put things? So if we do need to scrap something, if we have, oh, well, we've been doing this for years, oh, no, we can do that next thing.
Sure, measuring impact, right?
Measure the impact of what we do, but because the social service piece, I don't know how else to describe that, really, but that piece that we do, how can we turn those into tangible data pieces that we can measure to say, oh, look, we really caught this person at this point in the stage of their diagnosis instead of in full-blown crisis.
Yeah.
It's a really great question, and I won't be able to answer it, obviously, but it goes to a couple of points, and I'm gonna say two things. I'm gonna say them out loud so I don't forget the second one, because that's what I always do. So the first goes to the concept of precision public health, and then the second one goes to this large and growing body of evidence around unmet social needs. So I'll do social needs first. The Siren Network, which is housed out of the University of California, San Francisco. The Siren Network is a group of individuals who have built screening tools that do this incredible thing, which is to ask the next question, which is, I think, what you're getting to. So I was diagnosed with diabetes, or I was diagnosed with substance use disorder, and I need to get into treatment for those things. And we say, okay, great, we'll get you into treatment. And then we forget to ask the next question, which is, how do you get there? And we're doing in-home wraparound services and you are homeless, or we're trying to treat your diabetes and you live in a food desert where the neighborhood gas station is the only place that you can get your food. So how do we ask the next question? And it's hard because the things that you do on an individual basis, we are not asking people on a systemic level to say the thing that you do on an individual basis is working on a systemic level. And so I think there needs to be this fundamental frame shift in how we actually ask our questions. If you come into my County Division of Family Resources office and you say, I need to sign up for SNAP, I need to be able to say, okay, let's get you signed up. What else do you need? And then I need to record that information in a way that we can actually tangibly describe whether we met the need that they had. And then whether we met the need that they didn't even know that they had, that is the thing that's a game changer in the long run. So that's kind of number one. Number two is precision public health, which is, you've heard of precision health, which is you need to take the medicine that's right for you. If you take this medicine and you are this type of person, it doesn't work. So you should take something else. And we can actually know that for lots of different things. And public health should work the same way. So we have a big data set, and population health is great unless it forgets about you. And so precision public health is taking that big information and really being able to get it down to individual, block, group, zip code information, because we know that zip code to zip code, person to person, though I think this program might work, it actually doesn't. And so we can take that zoom in, zoom out, macro to micro in precision public health and answer your question. Hey, we've got a big problem of diabetes in this zip code, and we know that here's the service provider in that area. Is it working? We have to change the way, again, that we collect that information, what we're collecting and how it communicates with other things. Again, but once we do, I think we can answer those questions of what's working and what's not.
Yeah, now's a good time for me to be a contrarian a bit, I think, which is, you really have asked like the Indiana Jones question, right? Like this is, we find the Holy Grail, how do I measure impact? And this is things that people want to know. And Barbara Carper wrote this great piece years and years ago about ways of knowing, that there are lots of ways of knowing, and they can be aesthetic ways, they can be driven by data. And one of the, I think, as we discuss big data, I think one of the things that sometimes we have to stop and realize is that if I help a person, whatever that help is, whether it's a healthcare help or I lift them out of poverty or if I give them a place to sleep for the night, just because I can't show I did it on a macro scale doesn't mean it didn't happen. And this is sort of the sort of shadow side of big data, is that it's led us in many ways to a discussion where if we can't demonstrate at scale, it isn't true. And while we can't say that if I do it in this small way, it's true everywhere, it's sort of a logical fallacy to suggest that if I can't show it everywhere, it doesn't help you. And I think for social service providers especially, this is enormously challenging because funders and others have a right to expect that the money that they're giving for work leads to outcomes. And of course, social service providers see those outcomes in real time, instantly, every time they work with someone, right? And the answer isn't that they're wrong. The answer is that our community dialogue, our conversation around what truth is, right? What is truth for my humanities friends, right? This is a humanities discussion. What does it mean to know something? I think that's at the heart of this discussion, and that's the risk. So anyway, I don't know if that's a contrarian view, actually. I think we probably both agree. I just think it's one worth noting.
And it's really interesting because I'm a big believer in the starfish story, right? The kids walking down the beach, and the tides come in, and it's left hundreds of starfish. And a guy walks down and sees the kid throwing the starfish back into the ocean and says, "What are you doing? It's a complete waste of time. You're never going to be able to get all these starfish back in the ocean." And the kid says, pitches one and says, "Well, I got that one back in the ocean." Right? And so I think there's this incredible balance, and they don't have to be mutually exclusive between making sure that we're actively pitching starfish back into the ocean and then looking at what was the most effective way to get them back in there, and how do we make our efforts and our talents and our resources work to get as many as possible. Yeah, well, and it doesn't mean that you stop doing the one while you're working on the other. I mean, again, I'm not in any way touting this as the right way to do it, but I personally, for my own well-being, have to go work in the emergency department and know that I can still take care of a baby, so that I'm throwing a starfish back every once in a while. Because sometimes it takes so long to figure out how to throw them all back in that you lose your oomph and your passion for the work, because it still has to be real. And the real work doesn't happen behind the door or behind the desk or whatever. It happens where people are. And how do we most effectively support where people are, so that we don't run out of the ability to help them?
Jen Walthall. We'll be back after this commercial break. A question over there. Oh, we really are getting the wrap it up. So.
No. We're just going to try to get through a few more answers because we got some coming in from online.
Yeah, we're going to keep going. So don't worry. You've been waiting really patiently. You had your first hand up, but let me go over here. I'll come right back. You're in queue. I've got this. Go ahead.
So I'm going to marry a couple of things here. You were talking before about the opportunity to predict risky behavior. We're talking big data. There's sort of this perception for those who are out of the medical field that in 2015, especially in Indiana, Scott County exploded. All of a sudden, there was this crisis. Obviously, there were several things leading up to that. Has there been the opportunity to look at that big data and measure all of those other factors that were leading up to it that in 2011, 2012, 2013 that took us where it felt like crisis, or it was crisis in 2015 and suddenly became public knowledge?
Absolutely. So from a personal perspective, I think most of the people in the room know I was the medical incident command for our Scott County HIV response when I was deputy health commissioner. And so that moment of crisis, though it could have been our state's, potentially our country's greatest tragedy, became an opportunity not only to help our fellow Hoosiers in a very comprehensive and compassionate way, but it also became our opportunity to change the way that we do business. And really look at our information predictively in the moment, and then also our response so that we don't do that again. Not only here, but for others as well. So yeah, the signs, as you know, looking retrospectively of what were the things that lined up the Swiss cheese holes so that, you know, Scott County fell through. There's lots of things. And then there are lots of ways to prevent it from happening in the future. When you look decades back, this was an area that had an attractive job opportunity with some a business that was located there locally. A bunch of individuals that actually were from Hazard, Kentucky, moved with this canning business to Scott County, and that's where they worked. And that was the industry that kept Austin, Indiana alive and well and going well. There were a couple of other groups that came in that offered job opportunities, and when those jobs went away, the economy of this rural area absolutely bottomed out. And what was left behind was this incredible divide from groups of individuals that could kind of do what they needed to do, and then others that couldn't. And this fundamental despair set in. And when there is a lack of hope, it's really hard to combat that with much of anything else. And so the predictors that started to manifest what despair looks like were things like decrease in employment, decrease in educational attainment, decrease in income, an increase in hepatitis C, an increase in emergency department visits for multiple different types of substance use, an increase in infant mortality, an increase in smoking. You know, all of those public health predictors that we worry about kind of all confluent in one space. And a lot of folks raised the red flag that something was happening. One of my very good friends, Dr. Will Cook, who's the lone family practice doc in Austin, Indiana, has been, long before we got there, had been shouting from the rooftops, we've got something going on here, and it's a really big deal, and we need to do something about it. But as a lone human, how do you do it all alone? And community groups rallied together to try to support their community in a way that was meaningful. But it wasn't until everybody got the wake-up call that this is the natural consequence of all of these things together, that we don't just have substance use disorder, but we have hepatitis C, and we have bacterial endocarditis, we have skin abscesses, and then we have HIV, all together, that it's a whole lot easier to take care of one of those things than all of them. And we're going to have to change the way that we look at watching and waiting, and we're going to have to be a lot more aggressive about how we identify places at risk and help. And so I think your question was, have we looked at it? You bet. And do we have all the answers? No, but do we know what the root causes and the ways that we can not only help our current Hoosiers in need, but prevent others from having these same constellations of things occur? You bet.
Great, great. Next question, ma'am.
My question has to do with our need or the movement to collect big data. And one thing that I have not heard in the opioid discussions is the part of where you include families of those suffering from addiction. And it's more of a challenge that as you continue to collect big data, that you find a spot on a form that you're collecting data where you say, there's a box that says, family is very involved. Check that box, and so when there is something going on or there's something you want to try or whatever it is, that you can reach out directly to those families who have indicated that they are involved, that they want to help their addict. But that, I just challenge you to do that. It's collect that small data, because like I said, everything that it's all these groups, we're going to do all these things and help, you know, the opioids epidemic, and we have to face this, jobs, blah, 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 but you totally leave out the people who care for the addicts when they're discharged from rehab, when they're discharged from the hospital, when they overdose and they don't die, and they go back, they go somewhere. And you have the family who chooses to continue to care for that person. There's nothing that we have, I'm identifying myself, there's nothing that we have that we can go and say, teach me what I need to help this addict. So I'm asking you to, as you can continue to do the big stuff, that you find a way to help the people who are really on the front line to help us help you help the addict.
It's a absolutely perfect observation. Well, we can't do any big stuff unless we have the little stuff that becomes big, right? So it's a challenging one, and it's a question that I really love, and I get from families that have lost loved ones. And right now it starts with a big hug, and then we have a really good conversation of we have privacy laws that protect individuals sometimes to their own harm, right? If I can't tell an adult son's dad that he lost his health insurance and can't get his medicine anymore, the dad then feels responsible when that son overdoses and dies. That's a really hard question of how do we balance the protections that we have in place for individuals with the needs for the people that can help them to get them to where they need to be? And how do we make sure that we think about how many grandparents are taking care of their grandchildren while their parents are incarcerated? How do we make sure that we know that information when we're building programs for our communities and training and all the rest? It is that really important factor when we know things about people, that it's not just that if we start to know things like, do you have a car, or do you have a house, or do you have food, but do you have a person in your life who is your protective factor? My director of the Division of Mental Health and Addiction says it a little bit differently, but he says when someone is getting on the path to recovery, they need three things. They need a job, they need a house, and they need a date. And what he means by that is that they need a connection to people to make sure that that recovery is sustained. And so how do we build programs that have all of the treatment that you need, but it's also connected to what's next? So maintenance of recovery is a house, a job, and a date. And your point is incredibly well taken, and we will make sure that that winds its way through the philosophy of all that we do.
Good, good. Okay, yes. Okay, all right.
Jen, you laid out a three-part process for using big data to tackle the crisis. The first one was figuring out where is the problem, and how do we go to it. I think we're doing a really good job about that, and I moved last year from a public hospital system in the Silicon Valley that we're really interested in everything that we're doing here with big data. The second step was to have a range of options and to use those effectively, and I think we're doing okay with that. I think there's some options that we haven't adequately explored, but really the third piece was being able to know what's working from those range of options and having the courage to say what's not working and kill it. So that's my question is, what is not working? What are the programs, what are the approaches in Indiana that we know are not working? And what are we doing as a state to share that information with all of the general public? Because I don't think that's visible to say, we know it's not working, we're killing it, and if you're doing this in your community, you should kill it too.
So I think more than individual programs at this point, it's more philosophies. So I'll harken back to something I think I said before, which is the medical model. The idea that someone realizes that there's a thing, an issue going on, they go to their doctor tells them to do something, and then suddenly everything is better. Without any other things outside of the medical world, that's what got us into this mess. It doesn't work that way. So making sure that we expand our definition of what medical care is and where it can occur is really important. To that end, we will at Indiana Medicaid be supporting, I think there's someone in the corner over here who is talking about community health workers as actual parts of the medical community, so that medicine actually doesn't just occur in the clinic or in the hospital, but it occurs at your local coffee shop or in your home with just as much recognition that that helps advance our healthcare outcomes as really any other piece. And that maybe what you heard from the doctor you didn't understand, or you didn't particularly like, or you weren't ready to hear it, but that community health worker then comes in on the back end at home and says, hey, when you talked to your doctor last week, did they talk to you about stopping smoking, and here's how I can help connect you with the resources that you need and then support you through that process. So really expanding what healthcare looks like and where it's delivered is our first step to doing something differently than we've done before. I think the second thing is that what I've alluded to but not named for the last hour, which is including the social determinants of health into how we do health. So we're not just talking about making that diagnosis, but we're talking about making that diagnosis in the context of who you are, where you live, what your barriers are, and acknowledging those as well. At this point in my career, if I had the power to write a prescription for a house for someone and not a prescription for an antibiotic, I would choose a house almost every single time, unless you're actively dying in front of me. But taking that concept forward, I think, is how we move out of active emergency and into prevention, which is really where we want to be.
And I would just say that for an emergency room physician, right, to come up and tell you that the solution of social determinants of health represents, the power of a great Indiana university. So that's awesome. That's not normal. I think that's awesome. All right, we have an online question,
Last
or are we
one,
going to take another one? All right,
this is
online.
another question from Marion University's pharmacology class. Do you believe programs like InSpect have driven patients to non-prescription / unregulated drugs? And can big data help find a route to prevent this outcome from occurring, to prevent more devastating overdoses and deaths from unregulated medications?
What a fantastic question. You guys are so smart over there, Marion. I don't know that InSpect itself is a driver toward that. My dad, who is a very wise farmer, says that Mother Nature will always be 10 steps ahead of you. And it's sort of daunting to think about that. When there's a will, there's a way. We've seen an uptick in bad outcomes from gabapentin, which is a non-opiate medicine that apparently can accelerate the effects of opiates. It's an additive medicine. Who knew? Who's so smart that people could figure that out. The same thing happens with other medicines like ecstasy, which is a street drug. You can take DDAVP, which works in the brain to combat the sodium imbalance that ecstasy does. I mean, again, how do you figure that out? It's really stunning. So, folks are where there's a will, there's a way, and people will figure out, unfortunately, how to hurt themselves. So I don't think that InSpect in particular is the driver behind innovation in your basement chemist. I think the real driver is that we haven't fundamentally been able to figure out what drives individuals and societies towards substance use in the first place.
Yeah. I would just add that, on that question in particular, our colleague Louis Roca down in Bloomington at Indiana University has actually developed an amazingly large data set that looks at pixels inside of photographs, right? And what he's doing is looking at photos on social media to determine what drugs are in the photos, right? Because if you don't know what it is and you want to know, we can figure that out by looking at pixelated data. And his work's really fascinating work. And while that doesn't answer the specific call of the question, it does suggest big data to the rescue, right? Maybe or maybe not. This idea that we can at least prevent further harm by knowing what we're dealing with. So fascinating questions, and thank you all. And I think with that, I'll turn it over to Leah.
Yeah, so I want to first of all say thank you so much to Chad and Jennifer. And I was specifically told by WFY, no one's going to kick you out of here like at 5:30. So if you have additional questions and you guys have time, we encourage you to come up and ask and get those answered, and to eat more cheese as well. I would like to invite up to just help us kind of wrap up and conclude some of this part of the conversation, Claire Green, who is from the Richard M. Fairbanks Foundation. And I believe what's getting passed out right now is a handout that she has for everybody, just to kind of provide some wrap-up thoughts and tell us a little bit about what you guys are doing in the face of all of the questions we've been talking about today. So thanks, Claire.
Well, thank you very much, first of all, for the opportunity to wrap up after these two awesome speakers. I'm a data nerd and proud of it, so this was a great conversation, so thanks to you guys. Thank you to WFY for hosting us, and Indiana Humanities Council, of course, for putting on this great conversation. So I was asked to talk briefly about the work of the Richard M. Fairbanks Foundation to try to help tackle the opioid crisis, and then also to talk about how we're using data to inform the work that we're doing. So for those of you who are unfamiliar with our organization, we are a private charitable foundation based here in Indianapolis. We award grants just to folks working here in Marion County. And we are not affiliated with Fairbanks, the Addiction Treatment and Recovery Center. That's a common misconception. Same family name, which I can see the confusion, but we are separate entities. In 2015, right about the time the Scott County crisis came to national attention in the New York Times and elsewhere, our foundation went through a visioning exercise to try to establish our new goals for the next 5 to 10 years. And we decided that we need to look at the data to help us understand what was happening here in Indianapolis and the state of Indiana. So we turned to our trusted partner, Dean Paul Halverson at the Richard M. Fairbanks School of Public Health at IUPUI for some health data. And we were really shocked and alarmed to find out that we had one of the highest rates of smoking of large cities in the country. And also, by the way, we happen to be having this opioid crisis happening. So long story short, using that data helped us establish 2 new health goals for the foundation. And we decided just to focus on them to try to maximize our impact through our grant making. So we're focused on trying to reduce tobacco use and opioid use disorder in Marion County. The very first thing we did, because we knew these were problem areas, but we didn't know exactly how to go about changing the way we were making grants to try to make an impact there. So we commissioned a report from the School of Public Health on the opioid crisis here in Marion County and the rest of the state. And that was chock full of data around heroin, around prescription opioids. It was really fascinating. Available on our website if you'd ever like to take a look at that. And that helped us understand kind of the big picture statewide here in Marion County. There were really 3 recommendations that the report put forth. One was to focus on the immediate crisis by getting more treatment, expanding access to treatment for people, making that easier for them, expanding harm reduction services, so like in Scott County, making sure you actually had needle exchanges so people were not sharing dirty needles and spreading bloodborne illnesses and diseases. And then the third area was prevention. And something really jumped out from that report to us was that nationally, they knew that less than 15% of children were getting exposed to prevention programming in schools. So with our grant making, we immediately focused on treatment. That's where we jumped first. And actually, Jen mentioned this in her remarks. We gave a grant to Eskenazi Health Foundation for a program called Project Point. That was the brainchild of 2 ER docs who kept seeing people show up in the ER who'd overdosed, been revived with naloxone, discharged, and then they'd show up again. And they said there has to be a better way to approach this problem that we're seeing and help these people. As Jen mentioned, there's this window of opportunity when somebody's said, okay, I'm ready for help now. But then you discharge them with a referral and they don't follow up on that referral because they have to wait for 3 weeks or whatever the other barriers are that don't allow them to get there. So they had some small grant and had a little pilot going, but it was not 24/7, and they were seeing some promising outcomes. So our foundation awarded a grant to them to scale that up, try to actually put in place the structure that would be needed to maintain that. And then because we love data, we added on an evaluation component. So we will be working with IUPUI to evaluate the impact and see is that actually breaking the cycle and helping people get into and stay in treatment and stopping those repeat patients showing up in the ER. So that's one example. Then we decided we wanted to follow up on that little tidbit about prevention and what children were not being exposed to. And I have a couple pieces of data that really jumped out at me. Nationwide, 18% of students report having used a prescription drug for non-medical reasons by their senior year of high school, and nearly 90% of adult smokers started smoking before the age of 18. So we actually did a survey at the end of last year, in the late summer and the fall, of all 300 schools in Marion County, and what we found were that 11% of schools in Marion County are implementing evidence-based prevention programs in elementary, middle, or high school. So that means that we've got 89% of schools that are not getting any kind of evidence-based prevention programs in front of kids. So our latest initiative, we just announced it last week, and I have a handout that hopefully all of you received now with more information. We've called it Prevention Matters. It's a 3-year grant initiative for schools in Marion County for them to get a non-competitive planning grant and then get connected with a technical assistance provider who are experts in prevention to help them select an evidence-based program that they can implement in their school that makes the most sense for the age of the students that they serve, the culture of their school environment, et cetera, and then put together a plan to actually implement and sustain that. And then there will be a competitive phase where we will award 3 years of funding for those who can actually put together a really strong plan to show that they have selected an evidence-based prevention program and then have figured out a way that they think they can implement it and scale that up. And our board allocated $12 million to that over the next 3 years. So that's an example of how we're using data. It informs where we're directing our grant making. We evaluate everything. We also have a dashboard, which is on our website, rmff.org. We actively track data to know at a macro level what's happening, and then also at a micro level, what is the impact of the grants that we made it. And we do make a lot of mistakes too, so we'd like to know what's not working and what is actually showing some impact. So with that, I welcome you to ask me questions about Prevention Matters and the work of the foundation. And I'd again like to thank our awesome speakers, WFY and the Indiana Humanities Council.
So thank you guys so much. We're really, really grateful that you came out. If this kind of programming is important to you, make sure you let us know so that we can keep offering these kinds of discussions. I want to thank Chad and Jen again for giving up their time to do this, and Claire and the Fairbanks Foundation for supporting this conversation. And have a wonderful evening, and eat cheese on your way out. Okay.